Let's talk a bit about binge eating, compulsive eating, chronic dieting, and obesity. And the first thing to emphasize in relation to these is that they really don't represent any kind of official designation as disorders within the Diagnostic and Statistics Manual of Mental Disorders, the DSM-4-TR, the current version of the DSM. They may represent some problems, some struggles, some difficulties surrounding eating, but they don't really yet constitute officially designated disorders, although as we'll talk about, it may well be that one or more of these winds up getting classified as a disorder in the upcoming DSM-5 as that undergoes development. But currently, if someone was experiencing what we'll describe as binge eating, or compulsive eating, or significant serious struggles related to chronic dieting, they would have to get diagnosed under the category of EDNOS, eating disorder not otherwise specified, because again, they wouldn't meet the criteria for anorexia, and they wouldn't meet the criteria for bulimia. So as a result of that, the only other designation is eating disorder not otherwise specified. Well, let's take a look at each of these in turn. First of all, when we talk about binge eating disorder, we're talking about a kind of struggle or experience that is much more common than either anorexia or bulimia. Binge eating disorder, while it isn't officially recognized within the DSM, does have a research-related criteria set associated with it, so it is under consideration and is currently being studied for possible inclusion in the DSM. Binge eating disorder is marked by recurrent episodes of binge eating. The idea is that a person would be binging at least a couple of days per week for an extended period of time. In other words, it's not an occasional or acute condition, it's one that represents an ongoing pattern, a problematic and chronic pattern, much like the kind of criteria that attends both anorexia and bulimia. It can't be a passing problem, it has to be an enduring problem. Secondly, binge eating disorder is associated with feelings of impaired control over eating. And again, this reflects that sort of eating discontrol, the impulsive eating experience or criteria that's common, for example, in bulimia. The person doesn't control the eating. In a sense, the eating controls the person. And so this would be an individual who would start to eat something or would confront food and then just lose control and continue eating and eating and eating. It's very much like the binge aspect of the binge purge cycle within bulimia. And like that binge purge cycle within bulimia, it's accompanied by significant distress over the binge eating. This is very common to many, if not most disorders in the DSM, where there is significant personal or emotional distress. The person is concerned about, worried about, quite distressed over the binge, but simply can't control it. Importantly, the defining feature in relation to a binge eating disorder is the absence of any kind of regular compensatory behavior, very much unlike bulimia. There's no effort to undo the effects of the binge. There's no self-induced vomiting. There's no use of laxatives or diuretics or emetics. There is no compensatory exercising. There's nothing designed to stop or compensate for or undo the ingestion of all the calories associated with the binging. Well, needless to say, in the absence of compensatory behavior, all of the ingestion, the caloric intake, really registers an effect. So people who suffer from or experience a binge eating disorder in the absence of purging tend for that reason to be relatively overweight. Importantly, as with bulimia, the notion is that there will be a kind of rule out. That is, the symptoms of a binge eating disorder could not occur exclusively during periods of anorexia or bulimia. One way to think about that is that just as anorexia trumps bulimia, so too would anorexia and bulimia both trump binge eating disorder. You couldn't have a binge eating disorder, in other words, if you qualified for a full-blown bulimic disorder. So these are some of the thoughts that are currently guiding the development of a criteria set for binge eating disorder. A critical thing to recognize in relation to this is that there is an aspect of impaired control in a binge eating disorder. Indicators of that were things like an individual who eats very rapidly, and that is, like we discussed under bulimia, they may just simply be cramming the food in their mouth. They may not be attending to flavor. They may not be attending to the enjoyment. They're simply eating robotically, mechanically, or even quite rapidly. Importantly, in a binge eating disorder, the person will eat until they feel uncomfortably full. Now, many of us will eat some people will eat until they're no longer hungry. Many people eat until they are full. Here, these people tend to eat until they are uncomfortably full. They're full, they're uncomfortable, and they continue forcing more food down themselves. They are eating large amounts of food even when they're not hungry, because their eating is not in response to hunger cues so much as it is to emotional cues. They're binging, they're gorging. Importantly, oftentimes people suffering from a binge eating disorder really tend to eat alone out of embarrassment of being seen eating large quantities of food in public with other people. Now, this is important because they're concerned that in public, in a social context, they might actually lose control, like if they were to go to a party and to be a spread of hors d'oeuvres and foods, that they might actually lose control and humiliate themselves or shame themselves or embarrass themselves by just sort of continuously eating and stuffing down large quantities of food. So they actually fear discontrol, and for that reason tend to actually avoid public contexts where there might be the possibility of a kind of open or free feed that they couldn't control themselves or hold themselves back from or harness themselves in relation to. As in the case of bulimia, when they experience a kind of binge, it's followed by feelings of disgust, guilt, or depression as a consequence of that gorging. They feel badly about it. But again, this doesn't trigger, in the case of binge eating disorder, any act of purging, vomiting, or other kind of compensatory behaviors. Features that are associated with binge eating disorder include the following. First, as I've already mentioned, eating is often triggered emotionally. They're not eating and binging or gorging out of response to hunger. It's oftentimes out of response to an adverse emotional situation, just as in the case of bulimia. They can oftentimes binge during an episode or feeling a kind of dissociative quality, and many people who suffer from binge eating disorder will talk about that. They'll talk about it's almost as if they were on automatic pilot, like they were an automaton, almost as if I weren't really there. I was kind of watching myself just stuffing things into my mouth without even necessarily feeling like I was the one doing it. It had almost a surreal or otherworldly kind of quality to it. And so this is that notion of almost a dissociative episode that occurs when the person is not feeling like him or herself. They're just almost outside looking at themselves doing this sort of horrible overeating. Oftentimes, people with a binge eating disorder have a prior history of dieting and have a prior history of being overweight. On average, individuals who suffer from a binge eating disorder are more likely to be obese than they are normal weight, precisely because they're not engaging in compensatory behavior, and so those calories are being absorbed and ingested into the body and into the system. Because their days, their weeks, their months, and their years are accompanied by significant episodes of binging, it's also the case that they may have significant weight fluctuations. And you'll sometimes see this with binge eating disorders. They experience oftentimes an impairment in social and or occupationally related activities that are specifically due to the eating disorder. And again, if I fear that I will lose control in a public context, around food, then the tendency is to avoid those contexts. So I don't go to socials at work. I don't go over to people's houses. I don't go to parties, because those are contexts that would present me with maybe even an irresistible kind of allure and attraction and seduction to gorge, to overeat, to binge, and then to embarrass or humiliate myself. So the tendency then is for the social world to kind of shrink, particularly given that so many social occasions, so many parties, so many activities, when people, family, friends, co-workers get together, are around food. The tendency is to avoid those occasions and to have the social world kind of shrink or diminish, leaving the person relatively alone and isolated. Not surprising then, this contributes to increasing levels of depression, self-loathing, anxiety, and of course an ongoing sense of bodily concern and interpersonal sensitivity relative to normal population. So they develop a kind of vigilance around their eating, a kind of vigilance about their appearance, and a kind of self-hatred about not being able to control their eating. They avoid people, they feel anxious, they feel depressed, they don't want to be discovered, and so they wind up being relatively alone, relatively isolated, and relatively depressed. Well, what can we say about the prevalence of binge eating disorder? It's difficult to say. It's not an officially recognized disorder, so for that reason it's not well known or studied at this time, and that work in truth is taking place even as we speak. Best estimates currently are that the prevalence of binge eating disorder may be in the area of maybe 0.7% to 4% of the population. This would be non-patient community samples. So this would make it a pretty common disorder, if in fact it winds up being a disorder that is discrete and different from bulimia per se. It may be that rather than in non-patient community samples, in weight control programs, that binge eating disorder constitutes between 15 and 50% of those people who are in Jenny Craig programs, are in Weight Watchers programs, and so forth. In other words, because they tend to be relatively heavy and to have, by virtue of binging without purging or compensatory behavior, to gain weight and develop obesity, it's reasonable to expect that they might be overrepresented in weight control programs. They are concerned about their weight, they are concerned about their body image, and they don't have compensatory mechanisms to deal with their chronic binging behaviors. Women, the notion is, have a considerably higher prevalence rate than men, probably 1.5 times greater than men do in relation to binge eating disorder. The onset of the disorder is oftentimes in the late adolescent period or the early 20s. That's when the most common onset of binge eating disorder is, not unlike you would see with bulimia, but different than you would see with anorexia, which typically occurs somewhat earlier than that. And often the disorder begins after experiencing significant weight loss from dieting. This is important because what happens is that the person engages in a long period of restricted sort of dietary consciousness, dietary restriction, fasting, eating as little as they possibly can. This, of course, increases the body's hunger signals. The person becomes incredibly famished, very hungry, and it increases the likelihood that then they are going to go binge. So this is that almost a yo-yo diet writ large. The person self-starves, and then they get so hungry that they go and just gorge and feast. It's a little like the old notion that don't go to the grocery store when you're hungry because you'll buy so much more food. If you fast for a period of time and then you're given the opportunity to eat, the tendency is to overeat and binge. Well, there are a number of complications associated with binge eating disorder, and those include things like the following: higher serum levels, cholesterol levels in the blood, tendency to have high blood pressure, the tendency toward a risk factor for stroke, increased likelihood of diabetes, which is induced by taking too much glucose or sugar, heart disease, and depression, where between 15 and 50% of those people, for example, in weight loss programs, reflect levels of depression. What's happening here is we don't know cause and effect. For example, with depression, we don't know whether the depression causes a binge eating disorder or binge eating disorder causes depression. Most of this work in truth is correlational. But in terms of some of the medical things, it's pretty clear that many of these challenges and these medical conditions are the result of the ingestion at a chronic level, on a chronic basis, of very high sugar, fat, and saturated fatty foods. These are the things people tend to binge on. They tend not to binge on carrot sticks and celery. They tend to binge on ice cream or other candies or fatty chips and food and that sort of thing. So this puts a kind of strain on the metabolism. It results in the over-release of insulin as a way to compensate for this sort of blood sugar assault. So the person is in a way stressing and straining the body, the digestive system, and the metabolism that can trip a wide variety of these sort of medical problems. Let's turn then to talk a little bit about a second disorder that has to do with compulsive overeating. Compulsive overeating is a bit different than binge eating disorder. Again, it's under study, and it's not clear whether compulsive eating will be included in the DSM-5 or not, but it is the subject of some discussion and may be given some consideration in relation to possible inclusion. Again, like binge eating disorder, it's currently not yet officially recognized, and if you were to see compulsive overeating, then it would be diagnosed as a eating disorder not otherwise specified. Compulsive overeating is different from binge eating disorder. Binge eating disorder is marked by these very discrete, very acute episodes of gorging. Compulsive overeating, by comparison, is an individual who sort of continuously grazes. That is, they're always eating. The tendency is to be thinking about food, to be planning their food, their next opportunity to eat, to be fantasizing about different foods. They have an ongoing relationship with food. It occupies a fair amount of their waking lives. Importantly, in compulsive overeating, which basically is eating very regularly, almost consistently, almost continuously, the relationship between food is a much more positive relationship than it is with, for example, binge eating or bulimia, or certainly anorexia, where the relationship is negative or deeply ambivalent. By comparison, a compulsive overeater has a generally quite positive relationship to food. That is, they like food, they're attracted to food, they're always thinking about food favorably, they're anticipating food, they're looking forward to food. They're not fearful of food, they're not anxious about food, they don't feel guilty about food, they don't feel ashamed about eating. This has to do with the distinction between the gourmet and the gourmand. You'll recognize that a gourmet is somebody who has a fine taste, a cultivated palate, and can appreciate various food textures and flavors and the subtlety and nuance of various foods on the palate. By contrast to a gourmand is someone who is indiscriminate in his or her eating, simply loves to eat anything. Doesn't matter how subtle it is, doesn't matter how good it is, doesn't matter how fine it is. It's not about a particularly discriminating palate, it's about just continuously eating food. The compulsive overeater is much more like the gourmand. Let me say something then about obesity, because it's pretty clear here that in the case both of binge eating disorder and compulsive overeating, when there is no compensatory activity associated with the ingestion of that kind of calorie intake, that the person is ultimately over time going to increase in weight. They're going to gain some weight. And there's no doubt that obesity in our culture, just broadly and generally, is in fact increasing. It's increasing across time. And it's increasing in relation to a wide variety of things. First of all, we simply don't have the same level of activity that we once had. We're not primarily an agrarian culture. Farming has given way to a lot of white-collar work in which a lot less caloric expenditure is involved. Many more people are sitting behind computers and doing a variety of office and desk kind of jobs, and not nearly as many people are involved in hard manual labor, 8, 10, 12 hours a day. Relatedly, our culture is increasingly technologically driven. So we have cell phones. You don't even have to walk over to the phone anymore to pick it up. We have remotes on our TVs, so we don't even have to go up to change the channel. And in general, all these technological features are designed to make life easier. A lot more time is spent online. A lot more time is spent basically on our seats. And so the result is that we're not as active and we don't expend as much energy. But we do eat as much, so the tendency is for us to gain weight. A National Health and Nutrition Examination study found that a little over 50% of American women and 59% of American men are overweight or seriously overweight. And the way that that overweight designation currently is made is on the basis of the body mass index. And this shows what the definition for being overweight is for women and for men. For women, being overweight is having a body mass index between 27.3 and 32.3. That's the designation of being overweight for a woman. For a man, it's having a body mass index between 27.8 and 31.1. For women, being obese is defined as having a body mass index above 32.3, and for men above 31.1. That's the official medical definition for obesity. Interestingly, the men and women tend to gain weight at somewhat different periods of their developmental trajectory. For men, it's oftentimes that they gain their weight in their early 20s, whereas women tend to gain weight after menopause, typically when the production of estrogen changes dramatically. So here we can see the covariation between aspects of hormonal functioning and weight gain. I want to emphasize that the standards of what counts as overweight has changed. Those standards have changed across time. Originally, traditionally, even as little as 20 or 30 years ago, we kind of had an arbitrary criteria. We regarded people as overweight when they were 20% or more above the norm for, say, their age. But we now tend to look not at a percentage per se, but a body mass index, the BMI. Even still, the BMI doesn't take into account a wide variety of factors. It doesn't take into account, for example, the ratio of muscle and fat. We know muscle weighs a lot more, for example. It doesn't take into account differences in ethnicity, and we know those do exist. It doesn't take into account body frame and so forth. So it's still the case that the BMI definition for weight, being overweight or being obese, still doesn't take into account all the factors, but it probably is a little bit better than a single arbitrary percentage above a norm. Now I'm going to turn to talk a little bit about obesity and its changes across time in the United States to give you a sense of how we are sort of a fattening nation. And here let me emphasize a couple of things and give you a couple of images. Here are the obesity trends in America. And I think this is quite helpful to look at because here what we have is we have the states in one of three different colors. You'll see the states in which there were in 1985 no data available. Those are marked in white. Those in which less than 10% of the population was obese are in light blue. And those are in a medium blue color where 10 to 14% of the population in the state would be regarded as obese. Now here we're going to regard obesity as having a body mass index of 30 or greater. An example of that would be a woman who was 5 feet 4 inches being 30 pounds overweight. So again, you can see there are a smattering of states in which 10 to 14% of the population would be overweight by that definition, would be obese by that definition, and there are a smattering of states in which less than 10% of the population would be overweight, and a lot of states with no available data. Now let's take that map and let's just fast forward and look at the same thing in the year 1990. Now you can see, number one, there are relatively few white states. In other words, data are available in most states. Number two is the number of states in which less than 10% of the population is obese, according to this definition of obesity, have increased substantially, from a smattering to quite a few. And importantly, the number of states in which 10 to 14% of the population is obese have increased dramatically, from a smattering to a very substantial percentage of the overall United States, probably greater than 50%. Now let's take that same map and let's fast forward yet again 5 more years and go to 1995. In 1995, you can see that there now are no white states. There are data available in all states, and there are relatively few states, in fact I'm not sure I see any, in which there is fewer than 10% of the population that are obese. Instead, you roughly have the nation divided into halves. Pretty much half the states have 10 to 14% of their population being obese, and the other half have now a new category that is 15 to 19% of their population is obese. In other words, you see the fattening of the nation. Take this same map and let's just do one more episode of fast forwarding and go from 1995 to the year 2000. And now what do we see? Again, there are no states that have no available data. There are now no states that have fewer than 10% of the population obese. There is only one state that has 10 to 14% of its population as being obese, and now the states are roughly divided between those in which 15 to 19% of the population are obese and those in which greater than 20% of the population is obese. So you can see this general trend across time to become heavier and heavier, with higher and higher percentages of the population becoming progressively more obese. Obviously, if we were to fast forward to today, we could all be pretty certain what direction our predictions would be headed. Now, let me say something about chronic dieting and obesity, and this requires that we say something about set point theory. Set point theory has to do with the notion that each person's body has a kind of set point, or a genetically programmed desired weight range, the ideal place that your weight should be. And the body then regulates itself to maintain a kind of dynamic equilibrium around that set point. So when a person binges, or when they fast and restrict their food intake, the body either speeds up or slows down, in other words, engages in a kind of metabolic compensation. A good way to think of that is to think about a thermostat. When the temperature in your apartment, for example, falls below the temperature you set, the heat comes on to sort of warm things up in your room. When the temperature gets too hot, then the air conditioner comes on, again to return it by way of dynamic equilibrium to whatever the set point on your thermostat is. The relevance for set point theory in relation to weight is exactly analogous to this. That is, when you lose weight, then your body realizes, wait a second, I've got to kind of get going here and store up some fat. And so what it does is it slows the metabolism down, it extracts more calories out of the available food, and it tries to make that food last. On the other hand, when you gorge more, when you eat more, your body recognizes, wait a second, I've got to speed up my metabolism and burn off some of this stuff in order to keep my weight more or less constant. So that's the operation of set point theory. When the body is deprived of food, as I mentioned, it tends to increase feelings of hunger, and it changes the metabolism to weigh more food until its original set point is regained. It's really striving to kind of retain whatever the set point is. However, the body now tends to store more fat in order to protect itself against future restrictive eating. That is, episodes in which there isn't sufficient food available. This is why many people who diet in order to lose weight very quickly oftentimes wind up regaining the weight that they've lost, or even sometimes gaining more weight as a result. because what they do is, by virtue of losing weight, they're setting their metabolism down lower and lower and lower, and then when they do eat, the body kind of rebounds to store up that extra weight, to extract every available calorie out, because it is anticipating, you have taught it to anticipate, a scarcity of food, a restriction of food, and so it's going to get all it can get when it can get it, and it's going to convert it into fatty adipose tissue that can be used like a storage source, like a battery, for later energy expenditure and energy needs. Research has shown, for example, that of those people who lose 25 or more pounds, 90% of them regain all of that weight within 2 years. And within 5 years, virtually everyone regains that weight. 98% regain that weight. This is the notion of set point theory. I want to emphasize here an interesting irony, and that is that while 80 to 90% of individuals who are on diets at any one time are women, the truth of the matter is that more men are actually likely to be overweight. This speaks to sort of the double standard in our culture. That is, women tend to be valued according to how they look. And even though they may not be the most obese, the more obese of the two genders, the tendency is for them to actually concentrate on their appearance and to be more likely by far than men to be involved in weight restriction or dieting. I want to mention here that the relationship between weight and health is a really complex one and not completely and thoroughly understood, but it's probably not as simple of a relationship as is oftentimes portrayed in the media. In the media, it would appear as if obesity was a horrible, terrible thing, that it would be a major health hazard, one of the top health hazards, that obesity needs to be tackled, it needs to be addressed, and it needs to be reduced because it is causing horrible, deleterious kind of effects on our nation's health. And the truth is, the relationship between obesity and weight more generally and health consequences is not that well understood. It's certainly the case that weight is increasing across time. There is absolutely no doubt about that. Even among kids, unquestionably, we're a more sedentary culture. Kids used to be outside running around playing ball, playing cowboys and Indians, and just sort of running around, running amok, doing things. Now they're more likely to be playing video games, to be doing social networking sites like MySpace or Facebook, and they're more likely to be watching DVDs and watching television. So there's no doubt that weight is increasing even among young children. But the relationship between weight and health is not so clear. As early as 1969, the American Cancer Society's longitudinal study of men and women, following 800,000 of them across a 6-year period of time, began to question the relationship between weight and health. What they found in that study, among many other things, was that only weight loss dramatically increased the risk of premature death by heart attack or stroke. Not weight gain and not weight amount, but rather a substantial decrement, a loss in weight, seemed to be the thing that was related to an increase in heart disease or stroke. The notion here is that starvation or malnutrition associated with dieting may actually be the proximal cause of heart disease, arteriosclerosis, hypertension, and diabetes. And these are precisely the kinds of things that conventionally we tend to associate with obesity. And yet the literature suggests that being overweight itself doesn't seem to be a substantial risk factor, at least up to a point. It tends to be substantial weight loss or yo-yo dieting where there are substantial weight fluctuations that place the greatest stress and strain on the body. I mean, just mention here something about power, obesity, power, and stereotypes, because what we currently know is not always consonant with what our cultural stereotypes are concerning weight and obesity. In our culture, non-obese Americans, normal weight Americans, tend to have a higher socioeconomic status, that is, they tend to be more affluent, have more money, they tend to be better educated, and they tend to have greater access to dietary information and to health services. Well, this means then that they oftentimes can afford to have healthier, to eat more healthily, and of course to have more nutritional education and to know what good food and good eating habits consist of. And so this is an important issue because it may well be that the issues of weight and obesity are stratified culturally and economically within our culture. It may be that access to greater wealth, the greater distribution of wealth, would be a very effective way to combat issues of weight by making people provide them greater access to different food sources that would be more expensive, and to health care systems and to educational systems about good diet and eating. In our culture, we tend to have a profound weight stereotype. We tend to believe that overweight people are weak-willed, that they eat too much, that they're impulsive, that they're lazy, or that they're even immoral. Part of this owes to our Horatio Alger story. We have this notion of sort of rags to riches, that people can pull themselves up by the bootstraps, and that people are what they make of themselves. And if they are fat, if they are overweight, that they are obese, that they are also responsible for that. And it's simply a matter of the choices that you make that determine whether you will be fat or not fat, for example. So people get blamed for their body size as if they are wholly responsible for it. The truth of the matter is, and the book you're reading in this course, Body Wars, outlines this, in 12 of 13 studies, obese people have been found to eat the same or less than non-obese people, and they make largely the same or very similar food choices. So both in terms of what they eat and what they choose to eat, there doesn't seem to be substantial differences between people who experience obesity and people who are normal weight. Of course, this is normative and not idiosyncratic data, not individual differences, and it is the case, of course, that anyone could eat enough to become obese, and they could be wholly and completely responsible for that. But the other part of it is that a substantial percentage of weight is influenced by a genetic predisposition or a heritability loading. Evidence suggests that somewhere between 25% and 70% of adult weight is a direct result of genetic influences. Let me just give you a very quick obesity quiz, and we will see how you fare in relation to these questions. True or false? Weight is a reliable predictor of health. The answer is false. Weight is not a reliable predictor of health. Probably the most reliable predictor related to weight is that substantial weight loss, particularly rapid loss on a chronic basis as in yo-yo dieting, is predictive of health risks. Number 2, true or false, there are significant differences between the eating habits of normal and obese people. Again, false. There can be differences, but by and large the differences are fairly small, both in terms of the amount of food that they eat and in terms of the types of foods that they eat. Number 3, when it comes to weight, genetics may be more important than the environment or learned behavior. The answer is true. Number 4, the health problems associated with obesity may actually be the result of dieting. The answer is true. And finally, fat on the body is always a predictor of dangerous fat in the body, like clogged arteries. And here the answer is false. That's simply not true. If you're interested in more information about the role of obesity and weight and health, then I encourage you to take a look at this website, www.weight.com, where you'll find a variety of information about recent studies and findings concerning obesity, weight, and various health-related issues.